So a common foot and ankle condition that we'll end up seeing within our clinic at R2P, but it's really prevalent throughout the entire outpatient orthopedic sports medicine field, is plantar fasciitis. And I think this is one of those injuries where we all know what it looks like. We all know how to go about treating it in regards to what are we looking for from a problem list standpoint and what are our available interventions. But I remember something that I really struggled to get a good and really confident grasp on was how much do you prioritize the different interventions? How much do you allocate efforts into the clinic versus just education and home program implementation with this? So I think when you have individuals coming in with plantar fasciitis, something that you really need to zone in on is how and when did this start? And is this relatively an acute bout, or is it more of a chronic issue? And also, what have they done or what have they attempted leading up to their first encounter with you? And this is often going to drive really the patient's expectations in regards to what they're hoping to get from a PT treatment standpoint, and maybe in their minds what a PT session should look like, which is very important because that's going to help you with meeting expectations of the patient and not potentially underwhelming or overwhelming them on the first day. And then also, what has that individual done in regards to seeing other healthcare professionals prior to their interaction with you? And I think you kind of get two profiles of patients here. You either get the individual that they've been dealing with this for a long time, they've seen their orthopedic, they've seen a podiatrist, they've tried PT in the past, and they're just making their way to you because they had a friend or a family member or somebody say that they need to see you. But they can be tricky because by the time they've seen you, maybe they've already done all of your first steps that you would have in addressing plantar fasciitis. You know, maybe they've already tried rolling out their feet and tried rolling their calves. They tried a stretching routine. They've tried a strengthening routine. They've tried modifying activity and resting. And then you're kind of left with a blank slate of, all right, well, what do I do now? With those individuals, I think what you really have to do is deep dive from a subjective standpoint and figure out not only what have you tried, but how intentional have you been with those trials. Meaning a lot of people may hop on a foam roller once or twice, but they don't stick with it. Some people may try stretching their calves or stretching out their foot, but they don't stick with it. They may have been introduced to a strength training routine, but they lacked the consistency or they lacked the intentionality with regards to how it was being dosed. What was the frequency? What was the intensity? How are they monitoring set and rep schemes? And was it even strenuous enough to drive a physiological response with them? And then in regards to activity modification, what did that look like as well? Was it definitive restrictions or guidelines that were given to them, and did they actually carry them out? So when I have somebody come in with plantar fasciitis and they are that kind of patient profile that we just described, where they've seen a lot of people, they've trialed things in the past, I really want to zero in on what did we try, what did it actually look like as well, and have them show me, hey, take me through the stretches you were doing, take me through your foam rolling routine, show me those different calf raise activities you were doing or lower body strengthening drills, and make sure that what they're verbalizing is actually what you've had in mind. Because I have had patients that they say they've done it all, but then when you dive a little bit deeper, there's some ways that you can tweak and optimize what they had been performing. And then with that patient, also just setting expectations for them and how likely do you think this is going to change for the better, and how quickly do you anticipate those changes? And being able to forecast for the patient is very important just for buy-in and also getting consistency after the first day. Now, the other patient profile that you may see is the person who's a blank slate. They had this acute bout of plantar fasciitis, or maybe it has been a little bit more subacute or even chronic, but they've just never actually taken the time to address it. This is the person where I think you go through your subjective part of the eval with them, but then you just go through your traditional objective orthopedic testing and also just your functional landmarks that you're looking at from a baseline testing standpoint. And I think you'll be surprised to see just how many times there are some very low barriers to entry with regards to interventions. And buckets that I commonly find myself educating them on is figuring out what their current activity level is, what is most provocative of the issue that they have, and is there any correlations? Is it time of day? Is it duration of activity? Is it type of activity? Is it footwear related? And really being to zero in on what that most provocative activity is then allows you to figure out, do we need to completely remove that activity, or do we just need to be mindful of how much we're doing it and making sure that we have consistency with when and how that activity is occurring? And part of that has to do with, is it a leisure activity, or is it a work activity or an activity of daily living that they cannot avoid and it needs to be done? From an intervention standpoint, I think from a self-care educational endpoint, just self-efficacy, you can talk about the potential benefits of icing or heating or whatever, maybe just topical treatments they want to do, foam rolling, soft tissue work, things that they can do that may not physiologically drive change or drive healing of what's going on, but it may help with symptom relief and it may help with their daily tolerance. I think that's an important thing to either just clean up myths and misconceptions about, and just giving them some good information as to how and where that fits into their program. After that, you can really put this patient into either a mobility or a stability category. What does their ankle dorsiflexion look like? What does their big toe extension look like? Those are going to be things that you want to look at either with goniometric measurements or just taking a quick functional assessment by doing maybe like a heel to wall test with them, or some other active measure of closed kinetic chain dorsiflexion. From a strength or a stability standpoint, what does their balance and their proprioception look like? I mean, you have a wide variety of tests that you can do with that in regards to symmetrical or asymmetrical stances, bilateral or unilateral stances, and then modifying footwear and surface that they're on if you feel the need to go that route depending on what's provocative for them. But I think something that we should all implement is just localized tissue tolerance and strength endurance testing by doing heel raise test for the gastrocsoleus complex. What can they tolerate from a bilateral standpoint, from a unilateral standpoint? And you can standardize that either by just giving them a metronome that they have to keep beat with and seeing when they fatigue or when they can no longer tolerate or keep beat with the metronome, or when they start to excessively compensate with their strategy and how they're choosing to get that heel to raise off of the ground. The other thing that you can do is also look at isometric endurance or heel height, depending on how flared up they are. And some people may be so flared up that they can't tolerate the isotonic nature of that repetitive heel raise test, and you may need to go back to something more isometric or a single effort test, and you're just looking at the height at which they can raise their heel. And that's similar to how you would also treat somebody coming off of an Achilles injury or even like an Achilles surgery or something more invasive in the early stages with that. And then thinking outside the box and not just tunnel vision on the foot and the ankle, but how do they look with just other lower extremity strength testing, and whether that's body weight competency or common things that they're doing in the weight room. But getting an idea of, does their strength profile meet their activity demands, and are there any gross asymmetries between the involved side and the uninvolved side? But I think plantar fasciitis, it is something if you work in an outpatient orthopedic sports med field, you are going to encounter it. And just being well equipped with identifying the type of patient that is coming into the door, identifying common and key areas for improvement for them, and then also delineating, hey, what are you actually coming in for? What are your expectations? And what has been communicated to you already, and figuring out if what your plan of care matches up with what they had in mind. And if not, making sure you either fill those gaps, kind of rewrite that narrative for them, and make sure that you leave day one on the same page together.